Hi everyone, my name is Dr. Meyer. I'm an assistant professor of psychiatry here at USUS, and today we're going to be interviewing Simon Oster. Simon taught the Human Context in Healthcare course at USUS for over 30 years, and we're going to ask Simon some of the questions that he asked us. So Simon, the first question that everyone wanted to know was, what's the deal with empathy?
Well, most simply put, is the term itself, and it's a very romantic notion of feeling into, but the term was developed in art criticism. And it's one thing to talk about feeling into an inanimate object, but when you're dealing with another human being, I think it's dangerous to draw conclusions. Rather, just look at what gets called an empathic response as simply a response to another and use that as a basis for questioning. And that's the most important thing. The feelings that the doctor gets in a situation can most effectively be used in the therapeutic way by using those feelings to formulate a question. Because those feelings are not out of thin air. They are triggered by something. Now, one aspect of it is the doctor needs to know their own issues that may color very strongly what their reaction is. The simplest case is around the death of a parent. A patient may describe the death of a parent, but if the doctor had but if the doctor had a good relationship with his parent, a sympathetic response might be appropriate. But if the doctor had a bad relationship with a parent, which is not all that rare, usually they'll know to pursue the issue. But if the patient, indeed, as you say, had a bad relationship, a sympathetic response may be totally inappropriate and, in fact, alienate the patient. Because the patient's reaction was, I'm glad the son of a bitch died. The point is that empathy or any data that emerges in a medical situation, or really in any life situation, is most useful as a source of questioning rather than a source of conclusions. Because people's situations generally do elicit some kind of feeling response in the observer. Empathy is simply a feeling experience. And it's what you do with it that's important, not the experience itself. While the feelings are there, they're useful as guides to questioning. For example, I can feel compassion for an individual who is in a difficult situation, even as I think they're being perfect idiots in the way they're dealing with it. You know, if somebody describes a painful situation to me, I feel badly for them. Even, as I say, as I look at the situation, I almost have to laugh at the absurdity of it. And sometimes I do laugh, and the person I'm talking with gets angry, which is good, and then we explore what was going on. And that's usually rather productive. It's important that the physician be aware, be very cautious about assuming I understand that what somebody is saying, and rather to ask questions, to seek concrete examples of what they're trying to tell me, rather than using a feeling response. When they have a feeling response that they think is empathetic, then to simply cast it in the form of a question. I can imagine that someone in a situation similar to yours might feel thus and such. Was that true for you, or is that off the wall as far as you're concerned?
So that's really interesting. So what you're saying, which is not always the way empathy is taught, is that what your reaction is doesn't really matter. So if you, as a physician, had an abusive parent, you might be more sensitive or attuned to patients who had abusive parents versus the physician who had a healthy upbringing. You might be less attuned to that. But irregardless, neither of them should lead to the conclusion. They should both lead to the question.
Exactly.
Simon, how did you help students who struggled turning empathy into questions?
What I tried to do with a student was ask them to walk me through their reasoning about a situation. And in those situations, I might ask questions. If the student, for example, around the death of a parent is talking about positive things, I might ask, well, suppose the parent was abusive. What might the reaction be? In other words, to seek out the premises from which the student is operating, and then suggest that those premises may be applicable to the student themselves, and to a lot of others, but they aren't universally applicable. Well, going back to the death of a parent, socially, conventionally, for most people, it's a distressing situation. But in the case of an abusive parent, the reaction of, I'm glad the son of a bitch is gone. And one has to be very careful about that, because people are not a priori prepared to talk about abusive parents and their reactions to something bad happening to them. So one has to be very careful about making assumptions about any relationship. And if you have the feeling that you're experiencing something that the patient might be experiencing, be aware of your reactions. Trust there is validity to them, but first look at what you might be bringing to the situation that might be affecting your reaction. Emphasizing that it is perfectly okay to have a quite different reaction, because they haven't been taught to think about the empathy rather than to almost act on it. If you think about your reaction and think about what might have stimulated it, then you begin to see how you can formulate it in the form of a question. And as I've often said, the question is the physician's most powerful tool. Ask questions, because in many situations, the first reaction is to jump to conclusions and act or question on those, whereas questioning the basic issue of what the patient is experiencing and what might have gone into that from the patient's perspective, not from the physician's. That's what's important to explore.
Well, thanks, Simon. Thanks for chatting with us. Thanks, everybody. We'll have this video posted on the website for about a month. If you'd like to post a question or a comment, please feel free to do so below. We'll put all those comments together and bring Simon to USUS to read through them and respond.